That is the best way, the role of communication media, if elicited in that way. While what we ask not to do, not to publish photographs or notes related to suicide, not inform specific details about the suicide methods, not give simplistic reason, not glorify nor sensationalize suicide, not use religious or cultural stereotypes. So the best not to make it like an important news and event and try to look to the areas you want to let the audience pick lot of likes and comments. Usually you should look to the standards how the communication media should work in that area. Sorry. So intervention by health system is well known by you, that strengthening mental health policies, implementing policies to reduce harmful use of alcohol, as we said previously, has a good or high risk of suicide, promote increase to healthcare services and restriction of access of means of suicide according to the society and the laws. Last part of our talk is about suicide and COVID-19. As you know, nowadays, the pandemic of COVID caused uncertainties caused by the COVID-19 pandemic, coupled with global responses such as lockdowns, have heightened depression and anxiety, isolation, loneliness, financial concerns, anger, irritability. Furthermore, post-traumatic stress disorder, fears, increased use of alcohol and tobacco. All these has two directions. It intensifies risk from suicidal behavior in people who are traditionally considered as vulnerable, and also in people who were not considered in risk prior to the pandemic. So in both conditions, the present situation we predict have carrying higher risk for future suicide. So the challenges become more clear: fear and anxiety, economic crisis, helplessness. As you know all, currently no effective treatment present for COVID-19 pandemic, and uncertainty about length and impact of the condition. Usually, a lot of population ask about when we may get the vaccine and return back to our previous situation. Still, no clear-cut answer is behind, and broken our routines. All we as a doctors now, we presenting symposium through virtual online, while we were in previous years we were using such events in a place with more social contact, and probably this is better than nothing, but definitely this broken our routine. Drass said in 2020, according to the existing model in scientific literature, suicide and suicidal attempts are complex behavior. It's combination of psychotic disorder, previous suicide attempt, and negative stressful life events. COVID-19 and its consequences such as isolation, as we say, coping with death and economic difficulty may lead to emerging or exacerbating effects on suicidal thoughts and behavior. Roger, Stanley, and Joyner say also the COVID-19 pandemic may not have an immediate impact on the rates of suicide and attempts. However, given that it is likely to result in a confluence of risk factors for suicide and suicidal attempts, it is highly possible that the pandemic will lead to increase in rate of suicide and suicidal attempt in the long run. As we know all, there is a lot of research papers talking about reduction in amplitude of mental disorders and suicidality during catastrophic situations, for example, during World War I, II, but after that, the rate increased. So we predict after finishing the COVID stream and strength, probably the rate of psychiatric disorder and our subject of today's suicide may be more and more. So universal prevention for the situation of today is combat economic insecurity and unemployment, which happen worldwide, increase awareness of risk in community healthcare professionals, detect what to do and where to refer, and as we say earlier, mean restriction and responsible media reporting, avoid glamorizing, that's to say elevating and making big self-harm, minimize COVID stigma. That is what the time permits me to talk about, and I raise the WHO Prevention Day statement, say prevent suicide, tend the hand and save lives. Thanks for you. Now, thanks for your being patient with us. At the beginning, there were some technical problems. Now we present the third speaker, who is Dr. Imad Abdul Ghani, consultant psychiatrist, and he is head of Iraq Psychiatric Association and advisor of mental health in Ministry of Health in Iraq. His lecture title is Cross-Sectional Study of the Psychosocial Change in the Employee Working in the Ministry of Health in Baghdad during COVID-19. The floor for you, Dr. Imad.
شكرا جزيلا. أول شيء أقدم الشكر والامتنان إلى البروفيسور الدكتور وليد سرحان على محاضرة القيمة، وللدكتور سيروان، ولكل المشاركين والمحاضرين. أعتقد بينت المحاضرة ولا؟
لا لسه ما بين.
Dr. Ahmad, present now.
بس نافذة. نعم.
Yes.
طلعت المحاضرة؟ Okay. I will speak on mental health impact on the impact of COVID-19 on mental health on the community. I select when I come from the community, the workers, and I select the workers in the Ministry of Health headquarters. As you know, the common theme or the common subject now in the media and in the public is about COVID-19. So I have this study, my own goals to know or to identify the feelings and thoughts that affects members of society during the pandemic. Second, to know the most common psychological symptoms. I have considered on symptoms not as a disease that society suffer from during the pandemic, and to study the impact of pandemic on mechanism of communication between family members and society, and about the methods of coping and adapting to the psychological pressure that accompany the pandemic. Also, to study the effect of lockdown, quarantines, social isolation, and the use of protective equipment on mental health. Study justifications. We have some reasons to do this because we have in the Ministry of Health in Iraq some indicators of increase in registration of mental disorders, psychiatric morbidity, and social complications during the pandemic. And second reason, for the purpose of developing the mental health services and psychosocial support during the pandemic to have adaptation for this increase in the long-term increase in psychiatric morbidity. Third, the society has been exposed to a period of psychological, economic, and social stress during the pandemic. The study is cross-sectional study of sample consisting of 150 male and female employee working at the Ministry of Health headquarters, include 76 male and 74 female for the period from 14 to 28 of June of 2020 by answering deliberately the questionnaire by respondent, self-answering, with considering the protective measures. We have considering the protective measure from person to person. And the questionnaire was prepared by the Office of the National Mental Health Advisor for the purpose of studying the changes in the mental health and psychosocial state. So I will speak about the results. The first result, our study showed that about 44% they have a fear from the disease, and about 34% they have the spread of disease. As you know, now we are facing with increasing number in clinical setting with the diagnosis of generalized anxiety disorders, panic disorders because of these fears. And now, before days, they know new term included what called coronaphobia. As you know, fear with avoidance it is one of the phobia. So many of clients or patients avoid going to medical centers, to emergency rooms. One of my relatives, his son has joint swelling, and he avoided to go to orthopedic clinic because of fear of COVID-19. So he has a phobia of going to clinics or to emergency rooms. So it is affect the follow-up of many patients and the treatment and follow-up of many patients because of this phobia. This fear accompanied by our result by the other psychological symptoms. The most common symptoms we find, about 38% they have insomnia in this sample, and I think this is true. Go with the reality. Now many in general population suffering from insomnia, and about 44 feeling of sadness, and only 24.7% feeling distress. In comparison with the study in general population China, there is about 27.9% for depression. They have depression. This is done online study on mental health in China, and they have 31.6% for anxiety in general population. And they have insomnia in their sample about 29.9. It is near our results, and 24.4 for acute stress during the COVID COVID-19 pandemic. Another study in China, they have reported 28.8% reported moderate to severe anxiety symptoms, and 8.1% reported moderate to severe stress level. Another study in Egypt, it is participant among the public in Egypt, reported a higher prevalence of depression. It is 67.1% mild, and the moderate 44.6 moderate depression percent, and 22.5% severe. So it is 67 mild, 44 moderate, and 22.5 severe. This is a study in Egypt. And for an anxiety, mild 53.5, moderate 30.6, moderate in anxiety, and severe to very severe in anxiety 22.9%. For stress, 48.8% mild, moderate 33.8%, and severe to very severe about 15%. And inadequate sleeping, this is less than 6 hours per day, about 23.1%. So we have high figures in Egypt. I think this is all effect of COVID on the community. We expected that we have increase in anxiety and depressive symptoms among people who do not have pre-existing mental health. Even not only vulnerable groups, they have now anxiety, panic, and depression, but also other groups have now suffering from anxiety. I think there is this is from a study from Duan psychological in China. There is already evidence that the possibility has been under-recognized. They now highlight that till now they are under-recognized. So the figures may be in the community more higher, not consulting till now the mental health services, and will be later more and more. In our sample, this is unexpected that the fear from economic, it is less low number, 7.3, because most of the respondents are governmental employee and receiving continuous monthly salaries during the crisis. But now if we repeat, the questionnaire will be rise this percentage because of the delay of the salaries. I think in the June, no, there was no fear about the economic. In the rest of the world, in all the world, there is a fear, economic fear, because they lost their jobs, economic recession. I think this is now in the next months it will be increasing. And we have morely health anxiety. I think a misinterpretation of body sensation. Most of the patients coming to clinics, misinterpretation of headache or sore throat or fatigue, and he misunderstands this, that he has COVID. So then he go to investigation and go to for testing for COVID-19. I think this is because of maladaptive coping behaviors. In our sample, somatic symptoms represent about 37.2%. This is in our sample, feeling or suffering from somatic symptoms that include headache, joint and back pain, and to less extent stomach pain and heart palpitation. I think the most common somatic symptoms was headache for suffering. The problems of using a sedative hypnotics without consulting a doctor only in 2%. This is close to the percentage of drug use in the community. This is an Iraqi National Household Survey of Alcohol and Use Drug in 2014. It is represent only 1.2%. They used drugs drugs without consulting a doctor. So it is now closed, but we are expecting that substance abuse, alcohol increasing in the future because of this burden of the mental health. Despite of all of this, we give negative figures. Now we have positive mindset can go a long way in the managing through the difficult time. These positive thoughts were prevalent in about 46%. 46% of our samples have positive thoughts, and suicidal thoughts, 0. Maybe as Professor Sarwan said, that will be long term. Now 0, maybe after 1 year, 2 years, increasing to 10 or to 20%. I think this is linked to the coping mechanism. Why positive thoughts? Because of faith, gratitude, and skills of the respondent to deal with the pandemic. Because of resiliency of the community, how to deal with this pandemic on this stress. And we find increase in ability of 10% and stability and satisfaction. When we ask them, do you satisfied with the condition now? About 44 said yes, as we are satisfied. Despite the size of the successive repeated psychological pressure, in spite of the pressure, but the frustration was only in 22.7%. So most of them, they are satisfied and they adapt with the condition. Only 22, they are frustrated. It can be explained why this will have positive thinking and good coping mechanism, good adaptation, good ability to solve problems. It can be explained due to the role of helping others. You have solidarity, social solidarity, التضامن الاجتماعي, تكافل, and cooperation and collaboration between the families and between the friends and this is a protective factors for the community. The relationship between families, friends, and relatives, or Moscow community religious, are mostly characterized by collaboration and love. This is in the sample. How this we're asking about our relation with the others. They asked us answer that it is good and love in 56%, and there is no changing in the prevailing relation in 30%. In spite of the condition of social separation and isolation, economic hardship and lockdown, the level we had found the level of communication was very acceptable, in which intermittent contact for 50% and continuous communication 14%, and there was no change in communication at 17.3%. And the rate of interruption in communication was poor, only 18. In spite of this burden, only 18, there is interruption in communication. Also, the percentage of domestic violence was very small. As the media, rumors, and false beliefs that domestic violence increasing, we found only 4.7. Maybe this now, maybe you have in the future and in the remote, maybe increasing, or maybe our sample, they are workers and maybe they are educated and maybe dealing with the rumors and misleading ideas by avoiding how we ask them how you use to deal with the misleading ideas. They answer by avoiding hearing them at 39.3% and denying them at 24.7%. This is a good percentage by avoiding hearing them and denying them. And others, they answer how to deal with the misleading ideas and rumors. They sharing with the others in 24.7%. For why he shared with the others? For the purpose of reducing fears, to obtain reassurance and encouragement, trusting information from fact-based resources and can also help to reduce anxiety. We have in the sample a small number at 9.3% who يصدق الإشاعات which is close to the percentage of whom had been denied the epidemic as infectious disease. We asked them, first question, do you consider the pandemic as a virus? Only 6.7 denied that it is infectious disease or that the virus is the cause. And it is not near the number 9.3 who believe in the rumors. And we assessed the role of psychological education and the role of media and social networks like Facebook, Instagram, others, WhatsApp. The average level, they said that about 78 that they answer that it is a good impact on the spread of the illness. 78% they answered that it is a positive impact of the media on the COVID, on the what call it in the how to يعني يعني الأخبار حول الأخبار أو المعلومات حول الجائحة. All this indicate that the high percentage of the community communicates with reliable sources to obtain news in dealing with the pressure of daily life. يعني definitely they listen and watch good channels, maybe to Iraqi or national channels or international with good certainty to have information. The last question we asked about how you expectation for the prevention measures, lockdown and the quarantine, others. Only 53 answered is of beneficial, and about 18.7% it is causing. They answer that it is causing anxiety and stress, that lockdown, and about 14.3% they answer that it causes restricting freedom to the persons. Other last conclusions. Although there is an increase in the rate of fears on some psychological symptoms, but it is considered within the normal expected level. We expected that it will increase and there will be burden on mental health services with the spread of the pandemic, and it is negative impact on the mental health of society. Also, we are aware of expectation of the second wave of the COVID. We will expect more psychological suffering and complaint. The presence of high percentage of positive ideas, which are considered the life skills for society to deal with the crisis. Third, there is a change in social relations and communication to society due to the pandemic. This is adapting mechanism. Fourth, the results did not indicate an increase in misuse of sedative hypnotics or the domestic violence more than expectation due to the spread of the pandemic. And fifth, the positive effect of psychological education on mental health of the community. And thank you.
Bashar al-Assad, General Secretary for Iraqi Her lecture title is Depression and Physical. The floor is for you, Sabra.
Thank you, Dr. Sarwan. Good evening, everybody. I hope my screen is sharing now. This screen or no?
We wait Dr. Imad to remove the screen.
دكتورة براءة ممكن تفتح البرزنتيشن؟
فتحتها بس you are presenting to everyone بس يعني ماكو سكرين.
على شمال بس اضغطي على البرزنتيشن هاي على شمال واعرضيها فول سكرين.
It's okay. Now, my presentation is about depression and physical illnesses. Well, the sad facts about depression, it's high prevalence. Cross-national lifetime prevalence in high-income countries is 14.6%. And the life 12-month prevalence is 5.5%. Also, for low middle income countries, the high prevalence, lifetime prevalence is 11.1, and the 12-month prevalence is 5.9%. So it is so it is underdiagnosed, undertreated. There is increased suicidal and non-suicidal mortality. There is increased both mortality and morbidity in comorbid medical disorders. And there is the highest decrease of quality of life of all chronic disorders. Well, if we take example in terms of mean health score, depression exerts more of an impact than other chronic diseases like asthma, angina, arthritis, or diabetes. As you see here to the left, we have only a medical illness alone. When we get depression, we have lower result, and when there is depression with physical illness like depression with arthritis or angina, the result will decreases. And the lowest result was when there is depression and two chronic medical illnesses in terms of mean health score. Regarding the burden of depression, as you see, we have unipolar depression gets 65.5 DALYs. What we mean by DALYs is a disability adaptive life year. It is a unit used to measure amount of health loss due to injury or disease. So depression gets the highest result compared with other mental or neurological disorders. Physical symptoms may be part of depression. 69% of depressed patients present with somatic symptoms as their chief complaint. Example, they may present with headache, weakness, constipation, and even pain in the back, joint, or abdomen. So these can complicate the diagnosis and are possible cause of overlooked depression. Appropriate treatment in patients with self-reported depression and physical comorbidity. You see here in diabetes mellitus, appropriate treatment is 46%. Then we have hypertension, 39%, and heart disease, 34%, with arthritis, 33%. What we mean by appropriate is at least 4 prescription of antidepressant or a session of psychotherapy. If we take the timeline of events, which is first, depression or the physical illness, when we have physical illness come first, maybe the physiological disruption caused by the illness may induce the depressive symptoms, or could be depressive symptoms develop in response to the stress or burden of the being severely or chronically ill. And sometimes the drug that is used to treat the physical illness may induce depressive symptoms. And when depression came first, depression appeared to be a risk factor for a number of chronic physical illnesses, or a number of potential mechanisms have been suggested. So regardless of the order of occurrence, a subsequent intervening of two is likely. Prevalence of major depression is very high in the physical illnesses. We see in Alzheimer's disease is 11%, HIV 12%, coronary artery disease 17%, and the highest result was with Parkinson's disease, which is 51%. This is a study conducted between the year 1980 and 1990. They follow up patients who get myocardial infarctions and they get patient who gets stroke, for their probability of survival. So the red line, that curve, present the patients who get depression. We see that they have a low survivor rate than those who are not depressed following stroke after 10 years from the study began. The same thing for heart failure. They follow up patients who get heart failure, and they see that the survival rate with those who get depression was less than those who are not depressed. This study was done for patients who get myocardial infarction and had implanted a stent. This study is a multivariate analysis. It is conducted for patients who get diabetic and those who get not diabetics, and those who get adequate positive effect with no diabetes, they get less death. And those who get diabetes and adequate positive effect get less death than those who are has a reduced positive effect or anhedonia. So it is multivariate analysis. The positive effect of age and over 60 and being male were significant predictors. Here we get a relation between depression and smoking. Also in diabetic patients, those who are not depressed has lower rates of smoking than those who get minor depression, and it is lower than those who get major depression. So depression is associated with increased smoking among diabetic patients. Another study on depression and the basal metabolic index, which is over 30 among diabetic patients. They found that those who are not depressed has a lower basal metabolic index than those who get minor depression, and those who get major depression has very high basal metabolic index. Regarding depression might influence medical outcomes in patients with pre-existing medical illness. So patients who get cardiovascular disease, there's increase in their cardiac mortality by about 3.5 to 4-fold, and it predicts poor prognosis in patients with pre-existing coronary disease. Same for those who get stroke. Depression increases the mortality by 3 to 4-fold. And affected functional recovery for depression, increase the burden of seizure, decrease quality of life. For diabetes, might be increase the early onset of vascular complication. For cancer, increase the mortality by 2 to 6-folds. And for HIV, it is associated with illness progression to AIDS disease. Also, depression could be a risk factor for development of medical illness. It could be increase the risk of 1.5 to 2-fold to get coronary artery disease, the same for ischemic stroke, and it increased the risk for 4 to 6-fold to get epilepsy, also by 2.1 to get Alzheimer's diseases, and diabetes mellitus, 60% risk increase. Also for cancer might increase by 1.35 to 1.88 folds, and also for HIV, bipolar patients are vulnerable to get HIV disease. Here, depression and compliance in diabetes. As you see, this orange column represents those who are not depressed. So those who are not depressed get less non-adherence to taking oral hypoglycemic patient than those who are depressed. Also, those who are not depressed are less non-adherence in taking lipid-lowering medication or ACE inhibitors. Regarding diagnostic criteria, which is all of you know, for major depressive disorder, which is 5 or more of the following symptoms present for most of the day, every day for 2 weeks, depressed mood, anhedonia, and should be one of these two present, addition to weight loss or weight gain, insomnia, hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feeling of worthlessness or excessive or inappropriate guilt, diminished ability to think or concentrate, and recurrent thoughts of death or suicide. Some of these symptoms could easily be incorrectly attributed to a chronic physical illness and lead to misdiagnosis also. Here we have pooled analysis of 4 trials of Cipralex versus comparators. Summary of outcome out at 6 months. What we mean by comparators, they use 50% of them patient taking paroxetine and 55% others divided, half of them taking citalopram and the other half taking duloxetine. They found that there is a percentage of patients who get response. This column represents those who taking Cipralex is higher in response, remission, in complete remission, and in system-free comparing to the other drugs. Also, we have Cipralex has the highest probability of remission in all scenarios with a point of estimate of 0.46 when all studies are included. So they do multiple comparison meta-analysis. Different scenario include 8 to 12 weeks inpatient studies and 8 to 12 weeks outpatient studies and studies with flexible doses. In all these scenarios, there was a high percentage of remission with escitalopram, as you see this left column, compared to the other. The lowest one was fluvoxamine. Here we have a multi-center trial on depressed patients, DSM-4 defined and baseline and, according to Montgomery-Åsberg depression rating scale over 22. On patients aged 18 to 80 years were randomly assigned to 8 weeks of double-blind treatment with escitalopram 10 milligram per day, and others were sertraline 50 to 200 milligram per day. They found that Cipralex 10 milligram as effective as sertraline 50 to 200 milligram in major depressive disorder. As you see these two lines, this blue line represents Cipralex 10 milligram, the other line as it is between 50 to 200 milligram sertraline. You know that patients were not taking SSRI for their depression, they will get high number of sick days. This is before SSRI treatment, and when they take SSRI, the number of sick days will be less, of course. So treatment saves 5.56 days per patient. So sick leaves can vary between antidepressant, but here we have escitalopram, patient taking 20 milligram per day. They have less sick days than those who taking duloxetine 60 milligram per day. For treatment persistency and sustained treatment for single antidepressants, they follow, we have different antidepressants. As you see that escitalopram, this blue one, has the highest treatment persistency compared to the other antidepressant. The lowest one was fluoxetine. For frequency of a switch with different antidepressant, also we have here escitalopram, less switch frequency of a switch compared to other antidepressant. The highest one was fluvoxamine. Regarding efficacy and acceptability, you see here there is escitalopram has the highest acceptability and the highest efficacy comparing to other drugs. Second generation antidepressants are not equivalent in their potential pharmacokinetic drug interaction. Cipralex is among the second generation antidepressant with a favorable drug interaction. So regarding cytochrome enzyme inhibition, we have escitalopram has no inhibition on 3A4, weak inhibition on T2-6, no inhibition on 1A2, 2C19, and 2C9. So it is safe in combining with other drugs. So in summary, depression is at least as harmful as chronic physical illness. For many reasons, is not prioritized as much as chronic physical illnesses. Occurs surprisingly often in patients with chronic physical illness, can be a risk factor for the development of chronic physical illness and impairs the management of or exacerbate chronic physical illness. Antidepressants have different efficacy and safety profiles. Cipralex has been studied in several specific physical illnesses, demonstrating both efficacy and tolerability. A balanced integrated approach to both conditions is likely to improve overall treatment outcome. Thank you.
Thanks for you, Dr. Bara, for nice, informative subject. And if you stop sharing the screen, please. Now, the floor for Dr. Yusuf Ali Yassin, Assistant Prof of Psychology, College of Medicine, University of Duhok, Kurdistan region, Iraq. The subject title is Impact of Media on the Mental during the COVID pandemic. The floor for you. Do you hear me, Dr. Yusuf?
Yes, Doctor, I'm with you. ما أعرف.
دكتور شاشتك واضحة عندنا، بس افتح البرزنتيشن لو سمحت.
اوكي
واضحة هسه؟
واضحة، بس تقدر تسوي فول سكرين.
اوكي دكتور. هسه صار فور سكرين دكتور؟
اوكي.
اوكي. السلام عليكم اساتذتي الكرام، زملائي الاعزاء، اسعدتم مساء بكل خير. يسعدني ويشرفني ان اكون معكم في هذه الامسيه العلميه المميزه. شاف باش بو همي خشكو برا شاف باش. أود أن أقدم شكري لهولير ميديكال يونيفرسيتي، كردستان سايكاتريك أسوشيشن، إيراكي سايكاتريك أسوشيشن، وللشركة الداعمة والمنظمة، وشكر خاص لدكتور سيروان على جهوده. The topic that I will discuss is the impact of the social media on the mental health during the COVID-19 pandemic. Dr. Imad talked about some effect of the COVID pandemic on the mental health of the worker in the ministry. So we notice that social media, especially in our region, has a big impact on people, on people. Therefore, I chose this topic to be discussed today, and I will divide the talk to four main parts. One is the mental health and COVID, the social media, some research, quickly talk about them regarding the social media, and the summary at the end. So, mental health and the COVID, according to the WHO, it is normal and understandable that people are experiencing fear in the context of the COVID-19. It is normal and understandable. What will exacerbate or worsen that fear may be significant changes to our daily lives. Decreased movement, decreased going outside. In addition, working from home, temporary unemployment, and homeschooling of children, lack of physical contact with friends, family members, colleagues, all this may worsen the normal experience of the fear. Again, WHO, before few days, they published the result of rapid assessment of about the impact of COVID-19 on mental, neurological, and substance use services. This was in 5th of October, before 4 days. This report, it's published in the page of the WHO. This report of a survey completed by 130 countries during the period June to August 2020 provide information about the extent of disruption to mental, neurological, and substance use services, extent of disruption, and type of services that have been disrupted, and how countries are adapting to overcome these challenges. So the study rapid assessment was including 3 aspects: extent of disruption, type of disruption, and how the countries are adapting to overcome these challenges. And from the introduction to the publication also like that, I will just quickly, the pandemic quickly talk about it. The pandemic is increasing demand for mental health services. And bereavement, isolation, loss of income, fear are triggering mental health condition or exacerbating the existing ones. Many people may face increasing level of alcohol, insomnia, and anxiety. Meanwhile, COVID itself can lead to neurological mental complications such as delirium, agitation, and stroke. And even they mentioned people with pre-existing mental neurological substance use disorders are also more vulnerable to infection, to SARS-CoV-2 infection. They may stand a higher risk of severe outcome and even death. So for this reason, the pandemic is increasing the demand for mental health services. But what they saw or they noticed the survey find a major disruption to critical mental health services. So there is a major disruption in these 130 countries. And among the results in this survey, 60% report disruption to the mental health services for vulnerable people, disruption for mental health services for vulnerable people, 76 disruption to counseling, psychotherapy, including critical harm reduction, 35% disruption to emergency intervention, and 30% disruption to access to medication, and 3/4 disruption to school and workplace mental health services. So simply they notice that there is a very big, very major disruption to mental health services. And this made the Director General of the World WHO, Director General of the WHO to say that COVID-19 has interrupted essential mental health services around the world just when they are needed most. World leaders must move fast and decisively to invest more in life-saving mental health program during the pandemic and beyond. And tomorrow is the World Mental Health Day. They will announce for a campaign, big event campaign to move toward the mental health for the investment. So the COVID-19 definitely affect the mental health severely and caused major disruption, and this according to the WHO. One of the sources, one of the factor that played a key role in that, it was the social media. Really, that was the social media. Although the social media is like a two-sided weapon, positive and negative aspect, and it depends on the person who is using it. So the social media definitely carries some positive aspect. This should be mentioned also, like communication and similar, find friends with similar interests. Like now we have raised awareness on the important issues, support, emotional support, find outlet for your creativity, self-expression. So yes, social media carries positive aspect. And by the way you are using and what you are using, when you are using, is much more important than how much you are using. But of course, in addition to that, we have information, source of the information. So we are talking the positive aspect in regarding to the mental health, But at the same time, social media, generally talking, not just in the COVID-19, carries negative aspects, including inadequacy about your life or appearance. As we know, most of the people on the social media, usually they share the highlights of their lives. Despite we know that what we view on the social media is manipulated, but still it may cause some insecure or dissatisfaction. So inadequacy, especially for those who are using too much. fear of missing out. It's social anxiety. Social anxiety for that person who experience anxiety, believe that other may have fun, they are interesting, they are joyful, as if he or she is missing. So they will return to the mobile and the net and searching for the social media. So this fear, as if they are missing some fun, other they are interested. Fear of missing out, one of the negative aspects of the social media. Isolation. Some studies found that those who are using social media too much, they are isolated more. And depression and anxiety, they are also more. Nothing will replace the face-to-face meeting. Human beings, if they want to decrease the stress and the burden, they need face-to-face meeting, and never the social media never replace face-to-face meeting. Therefore, depression and anxiety is commoner. Cyberbullying or bullying through the internet, it's some research, 10% of teenagers, they have been bullied by through the internet. And self-absorption. Social media make the person to live within his or her own life, too much selfies, and sharing your valuable ideas to social media alone. So too much using the machines make you to self-absorption. So look to these negative aspect of the social media, and this is, by the way, generally talking, not just in the COVID-19 period. This is the vicious now about the vicious cycle of unhealthy social media use. Unhealthy use. Here, when any person feels lonely or slightly depressed, slightly anxious, slightly stressed, nowadays they will use social media more often. They will touch their mobile and look to social media mostly, and this will lead to this social. We said that fear of missing out and feeling of inadequacy, maybe dissatisfaction and more isolation, and they will feel more lonely, more depressed, more anxious, and use the social media more. This is the vicious cycle of unhealthy social media use. Again, I will say that it is a two-sided weapon depending on the way you are using. Studies found that the way you are using is much more important than the time. And this was about the social media. Now the third part is some studies or research about the effect of the social media on the mental health. So one of the study titled under the mental health problems and social media exposure during COVID-19 outbreak, it have been published in the Public Library of Science, Public Library of Science in the April, and in which the total of 4,872 participants from 31 provinces and autonomous regions of the China have been involved. More than 4,000 from 31 provinces, autonomous region in China have been involved in this study. Mental health and social media exposure, and they use the WHO-5 and generalized anxiety scale, these two questionnaires. The result, they found that depression more than 48% depressed, anxiety more than 22%, combination of depression and anxiety more than 90%. And more than 80% of the participants reported frequently exposed to social media. Most of them frequently, too much using, and frequently social media exposure was positively associated with high anxiety and combination of depression and anxiety. So most of them, they were too much using social media, and social media exposure positively associated with anxiety and combination of depression and anxiety. Another study again still in China, mental health risk factors, social media use during the COVID epidemic, and Code Frontier means lockdown. This has been done published in the PubMed, a journal of medical internet research, Journal of Medical Internet Research. PubMed published it in the 1,577 community-based adults participated in the research, in addition to 214 health professionals. This study has been done in Wuhan, the city where the COVID started and spread. And they use these two questionnaires. The result, again, here, community-based adult, the community of the adult, 1/5, they report an anxiety. And probable depression, it was near 20%. A significant depression. So for health professional, again, 1/5, they reported an anxiety and around 20% depression. So they are high percentage. 1/3 of the community-based spend more than 2 hours daily in COVID. So 1/3, 2 hours. And here, one of the strange results, close contact with individual with COVID-19 and those spending more than 2 hours, close contact, also they were associated with probable anxiety and depression. So in community-based adults. So even the close contact with COVID-19 and spending more than 2 hours are more probable to anxiety. Social support associated with low probable anxiety and depression in both. Another study, again, social media use and mental health during COVID pandemic among some students. Again, the PubMed published this article, a sample of 512 Chinese college students, 500, the result they show a high level of social media use was associated with worse mental health. This is in summary, and more exposure to the disaster news via the social media was associated with greater depression for participants with a high level of disaster stressor. So high level of social media use was associated with worse mental health. Leaving the China's and Wuhan and start from coming to the Iraq and specifically the Kurdistan region of Iraq. A survey-like study have been done by some colleagues, the impact of social media on panic during the COVID-19 pandemic in Iraqi Kurdistan. Here, the panic, they mean the excessive anxiety, really. And with all respect to the authors, but it is a survey-like study and will give some hints about the result. So 516 social users were involved in the study, through online survey. The result: majority of the participants, they were used Facebook to acquire information, and a high proportion of the participants, 76%, they were following or looking for health news regarding the COVID-19 rather than the politics, sport, art till the end. More than 38% of the participants were psychologically affected. They have significant fear. And this percentage may be near of the what have been mentioned by Dr. Imad also Abu Ramorkar, fear from diseases. When they ask which type of news they affected them too much, they choose this one, fake news about the COVID. Most of them, around more than 25%, they choose the fake news, not true news, wrong news. They affected us too much, more than the publishing the number of the infected person or the death. And this is our, me, Dr. Youssef, with some colleagues in College of Medicine. We did an online research also under the title, The Impact of the Following COVID-19 News and Its Association with Stress, Depression, Insomnia among the medical student, Duhok medical student. Still not published. We finished it, but still not published. So 345 students participated. There was 55.2%, and we used the DAS questionnaire and insomnia severity index. The presence of online time spending searching for the COVID-19 news with a score above 40%. Those who use the 40% of their time looking for the COVID-19s, following the COVID-19 are mostly through the social media. They regarded as significant following the COVID. The result: 32% 0.5% of the participant students were significantly following the COVID. Significantly, and by the way, this was done of the lockdown and the guarantee in the April. 2 weeks of the guarantee. And the prevalence of stress, it was the beginning of the COVID in the York City and the period of the guarantee under lockdown. So therefore, the percentage stress more than 42%, significant stress, depression more than around 60%, significant depression, insomnia more than 50. Really, they are high percentage. And a significant statistical association was found between following COVID news and stress, depression, insomnia with significant p-values. So those who significantly follow the COVID-19s, they were higher risk of developing stress, depression, insomnia. And in summary or the conclusion, social media has played a key role in disrupting the mental health and spreading stress and anxiety during the COVID-19 pandemic, and especially in Kurdistan region of Iraq and Duhok. And in addition, the government and non-government agencies. So this is like a comment, government agencies like ministries, whether the health, higher education, culture, religious affairs, and non-governmental agencies, especially the Iraqi Psychiatric Association, Kurdistan Psychiatric Association, need to pay more attention to the mental health problem, including social media, infodemic al-waba al-i'lami, while struggling the effect of the COVID-19 pandemic. وأعتقد بأنه that person, veterinarian doctor who talk about the dexamethasone بغداد حكى عن dexamethasone الأطباء شون خلال فترة قصيرة more than 5,000 shares, and its effect, it reached the Duhok also. It caused some sort of the panic and mistrust between the doctors and the population. If it was not social media, never that satellite channel was able to reach all these people. And thank you very much.
Thank you, Dr. Youssef, for a nice cover of the subject, but I think exceed the limit of time. Never mind, the subject was stimulating. We let you continue. Now, our next speaker is Dr. Hamid. We'll talk about Dr. Hamid is a special psychiatrist. Hamid Yunus Hamid from Diwaniyah, special psychiatrist, and his subject title is different from what we talk. Definitely this I do encourage him for another subject, is a bit of it, and the future. We hope that if we be able to do another webinar, select a subject, and our talk all be on the same topic, I think it's preferable for audience to concentrate on one issue. This subject, very nice review of book, The Creative Brain, The Neuroscience of Venus. The floor for you, Dr. Hamid, and I hope that we interested in this subject from your side.
شكرا أستاذ سيروان. مرحبا بكم الأساتذة والزملاء الأفاضل من أطباء وطبيبات نفسيين اختصاص أو طلبة دراسات في كل مكان. السلام عليكم ورحمة الله. معكم زميلكم دكتور حميد يونس. ألتقي بكم اليوم في مراجعة وقراءة لبعض كتب الطب النفسي الحديث وفلسفات الطب النفسي الحديثة. قد يكون الموضوع مثل ما قال الدكتور سيروان هو خارج السياق العام، لكنه كنت أنا محضره مسبقا فأعتذر للإشكال. Really, I thrilled and honored to be a part of this thoughtful gathering and talk with you about this book, The Creative Brain, The Neuroscience of Genius, and to share my idea about it and to just exhibit its information. The book combines both fun, knowledge, and information, and I rushed to translate it into Arabic language because it had a novel and unusual ideas about the creative brain, without the usual textbook terms and the jargon medical language. The author of the book, Nancy Cooper Andreasen, is an American neuroscientist and psychiatrist. She is actively involved in neuroimaging research, functional MRI, PET scan. She has written a lot of articles and books about neuroimaging and its application in psychiatry, as well as 500 articles and books about schizophrenia, about creativity, creative brain, the revolutionary genetic advance in psychiatry. In this book, exactly, she wants to answer the following question. Where does the creative spark come from? How do the human brain produce dreams and visions that become transformed into places of insight? Why are some human beings so highly creative that we recognize them as true geniuses? Is there any relationship between the creativity and mental illnesses? And can we instill the creative capacity in our children, or can instill the creative capacity in the future generations? The first question that she discussed, how the human brain creates the ideas, or more specifically, how consciousness and how the unconsciousness formulate the new thoughts. It is not easy to study the concept of a psychoanalysis like consciousness or unconsciousness in light of neuroscience terms, obviously, because the terms, the conditions, and the school itself differ and not interconnected. It is too difficult to examine the neural basis of the unconsciousness experimentally and scientifically. But she decided to use a neuroimaging technology. By measurement of the cerebral blood flow, she could determine the region of the brain that become activated during the conscious thinking and the unconscious thinking. By using PET scan, all subjects were asked to describe what they did that day, what they do in the day of the examination. Starting from when get up in the morning, this generates a narrative comprised of conscious logical speech that draw into the episodic memory. Then compare this state of mind with what they name it rest or random episodic silent thought, which is mean the unconscious thinking. This research permits to probe the brain region used for conscious episodic memory compared with the unconscious episodic memory. Then this comparison will give us a window into the neural basis of the unconsciousness. The finding of this weird study was thoughtful, as the brain region had become active during the unconscious thinking, where almost the region was the association cortices. Every association cortex, whether it was in the frontal lobe, parietal lobe, temporal lobe, are known to gather information from the senses or from elsewhere in the brain and link it all together. They activated and interconnected in potentially novel way each time and with every thought. These association cortices are the last to be mature in the human being. They are larger in the human being than in other higher primates. They have a more complicated columnar organization than other part of the brain. They receive input from the primary sensory or motor region, from the subcortical region such as the thalamus or other parts of the subcortical region are from one another. This organization permits the brain owner to integrate information that she or he process and produce much of the activity that we refer as the unconscious thinking or the unconscious mind. When the brain think in a free and uncensored fashion, it uses the most human complex part in the brain, which is what he called the association cortex. Now, if we want to understand how to build better brain, we need to understand how the brain develop and continue to grow and change throughout life. The author Nancy Andreasen argued that the creativity returned to the process of the brain plasticity, neuroplasticity, the process that began during the second or third month after conception. As the neurons arrive in the cortex, the brain also begins to wire itself through process known in the neuroscience as the axon formulation, dendritic proliferation, and synaptogenesis. These complex sets of network permit the human brain to be the most elegant self-organizing system in the universe that take place while the infant is still growing in the infant uterus. Now, each of the 100 billion neurons must reach out and touch approximately 1,000 target cells by sending out axon to make contact with the target. Dendrites begin to sprout, synapses begin to form. This process proceeds, the brain grows and expands in size, and by the 7th month in the uterus, it becomes or resembles the real human brain. And depending on where the neurons arrive and how they become wired to one another, they differentiate to create a specific functional region that make the necessary tasks like seeing, hearing, smelling, or moving the body, and all the other things that our brain commands us to do. Now, this leads us to the natural important question. Do we know anything about how the human brain changes in people who are creative? Fortunately, the answer to that question is yes. One important part, it depends on elements or in the neuroplasticity or brain plasticity, is remodeling or the ability to retain and store specific memories. The second important component is the critical period. The critical period are relatively limited window of opportunity during which the brain can learn, change, and develop. The opportunity is not seized during that critical period, and the window may close forever. One of the first important study to address this question chose an interesting group of subjects who were required to have a significantly enhanced spatial navigation skills by studying the size of the hippocampus in London taxi driver. London taxi drivers were chosen for this study specifically because they are subjected to intense training that lasts 2 years. They required to learn how to locate thousands of sites in London, in this city, and pass difficult police examinations. The examiner found that the London taxi driver have an increase in the size of the hippocampus compared to the control group, and the increase was correlated with the number of years spent driving the taxi. And they concluded that it seems there is a capacity for local neural plastic changes occur in the structure of the healthy human brain in response to the environmental demand. Now, what is the creativity? Well, we can define creativity in many ways. If we skip the boundary issues such as the distinction between intelligence and creativity, the terms such as genius, gifted, talented, and creative are often used interchangeably. The first effort to define and study creativity with a systematic tool of modern psychological study was conducted by Louis Terman at Stanford University. Louis Terman began with the assumption that genius and high intelligence were the same thing. Starting in 1921, he launched a study of genius, which is continued after his death in 1956. Alfred Binet, on the other hand, have created the first test of intelligence, inspired partially by observation of his two daughters, how they developed. Binet created a group of simple tests of memory and reasoning, By 1910, he began to take into account that the child knowledge changes and increase with age. He tested large number of children and determined how the average child performed on his test. The average for each age, the mental age, equated on the chronological age by using a ratio, the IQ equal mental age over the chronicle age multiplied by 100, as all we know what the result and its detail. But Terman, on the other hand, follow up the idea of Binier, given his own interest in creativity and intelligence and giftedness, and working with several of his students at Stanford. Terman developed an English adaptation of the Binier text. Then he honored the contribution of his Stanford student as well as Binier and called it Stanford Binier test. In that somewhat altruistic and less greedy, he provided the royalty earned by this test used for psychological research, not for his own personal gain. After he created the test, Terman selected number of gifted children and devised a variety of measurement to examine nearly every aspect of lives of these children. He examined the intellectual success of the relatives, body size measurement, medical history and examination, educational history and achievement, personality testing, intellectual and recreational interest. After the initial assessment, the evaluation continues systematically throughout each lifetime. In the adolescent, in the adulthood, in the midlife, and included the physical and emotional development, the occupational achievement, the marital adjustment, and the emotional and physical health. Then Terman, these selected children that Terman selected was typically above the population norm or control group value. They were stronger, physically healthier, more successful both economically and socially, although the psychiatric illnesses were not evaluated in a sophisticated way. But Terman geniuses appear to have a good level of psychological health and reasonably good family adjustment. In general, as the cohort matured, the member not produce a significant number of creativity in the future. There were very few successful writer or musician or artist or scientist. The profile of the Terman geniuses at the midlife in the early 40s indicated a decline in the professional and marital success, and there is no striking level of creativity. And despite their high IQ, there were no Nobel Prize winner in this group. In fact, William Shockley and Luis Alvarez, that eliminated from the list at the time of they selected the Terman geniuses, they nominated to Nobel Award in Physics. In result, as if there is probably a general agreement that certain level of intelligence is needed in order to make a creative contribution of some kind, but at some point there were elements of the creativity that permit some people to write novels or create equation or play a symphony that is not dependent on the intelligence only. Now, the next question, is there any relationship between the creativity and mental illness? Early study of the relationship between creativity and mental illness returned to work of Australian psychiatrist Adil Jodha. Adil Jodha attempted to conduct an interview and examine documents of famous people to evaluate the relationship between the geniuses and the mental illness. Jodha listed large number of them in order to obtain the appropriate sample, then shrunk the list to nearly 300. The group of artists, 12 architects, 18 artists, 20 painters, 26 musicians, and 37 poets. Most common mental illnesses they included was psychopath. The diagnoses that she included in this group are somewhat different from ours. It may consider to resemble our DSM category of personality disorder rather than the exact psychopath. This was the first study that identified the relationship between the creativity and mental illness. But the examination and the categorization of the disorders are somewhat difficult to interpret because her terminology is antique and it is not clear how to she diagnose and could we translate it in contemporary way. The second study, which is AWA Writer Workshop Study. In AWA University, there were a workshop for writers. They go with their manuscript, exchange idea about writing. Many of the writers were famous and creative in the aspect of the literature and poetry. The author Nancy Andreasen conducted a structured interview study using a diagnostic criteria, but before the APA, American Psychiatric Association of DSM-3, she wrote a criteria by herself. Then she go to the writers in the workshop study and confirm two ideas. The first idea that gifted people are in fact supernormal or superior in many ways. The writers were charming, fun, articulate, and disciplined. They followed very similar schedule, getting up early in the morning, allocated a large chunk of time to write during the earlier part of the day, but they had a lot of relationship with their friends and family. But on the other hand, they manifested a great symptoms and significant symptoms of mood disorders. Detailing this study done by the psychologist Kay Jamison in her amazing books about bipolar disorders. One of her books I reviewed before. She examined 47 poets, playwrights, novelists, biographers, and artists in England. Although she didn't use structured diagnostic interview or diagnose based on diagnostic criteria, but she detailed information about the history and type of the treatment. And she found that 38 of the total sample of the treated creative had affective illness. And with the higher rate occurring in the playwrights and the second higher rate occurring in the poets. And the group of artists also suffer from premature death, with nearly 50% dying before the age of 60 by suicide. After you read this book, you could be able to conclude how to answer these difficult questions, like where the creativity comes from and how we can nourish it. And is there any relationship between creativity and mental illness? The work of Andreasen is amazing. Although she didn't find all the answers and didn't provide enough evidence to support her position, but she rejected the absolute conception that we could answer all the questions at once. Instead, she opened the doors for all the suggestions and possibilities. Thank you very much.
Thank you, Dr. Abdul Hamid. Indeed, it was a new subject, and me personally interested in the subject. I hope that you got future chance to elaborate more on similar topics. Sorry for this long time you spent with us, but definitely the last topic is a stimulating one, and Dr. Walid will cover the last piece of our symposium of today. He is talking about psychological effects of cannabis. The floor for you, Dr. Walid.
شكرا جزيلا. الواقع يعني we are all aware of cannabis that comes from Cannabis sativa, and this plant which produce THC, delta-9 tetrahydrocannabinol, as a psychoactive ingredient. Marijuana is most commonly available psychoactive drug, and it has derivatives from hashish, grass, resin. The THC is 10 to 20%. Others dried tops 5 to 8%. Marijuana and others 2 to 5%. The medicinal use of cannabis-based products and cannabinoids. Key terms: cannabinoid is a drug that acts on the endocannabinoid system. The cannabis plant synthesizes many cannabinoids such as THC and CBD.
عفوا دكتور بس الشيرنج
مش واضح.
ماكو اصلا.
ماكو شيرنج.
ما في شيرنج. الآن
ستيل.
يس دكتور بيرفكت، بس افتح البرزنتيشن حطها فول سكرين.
واضح؟
بس واضح، بس سوي فول. ممتاز.
The main topic is the endocannabinoid system. The endocannabinoid system in our body regulates all these areas: neural development, memory, cognitive reward, emetic reflex, heart rate, GI motility, female reproductive function, immune function, intracellular pressure, stress and appetite, coordination. CP1 in the brain, cortex, nucleus accumbens, basal ganglia, hypothalamus, cerebellum, hippocampus, amygdala, spinal cord. CP2 in the brain, glial cells and brainstem. The endocannabinoid system, retrograde neurotransmission. This is very peculiar because this is against the neurotransmission we know. The first step that is the endocannabinoid precursor in lipid membrane. Second is neurotransmitter binding or depolarization triggers enzymatic reaction to form and release endocannabinoid. And the third is the released endocannabinoid binds to presynaptic CB1 or CB2, CB1 cannabinoid 1, cannabinoid 2 receptors. And number 4 is inhibit the release of inhibitory and excitatory neurotransmitter. So this is rather strange in neurotransmission and called the retrograde neurotransmission. The endocannabinoid system receptors and ligands, central and peripheral neuron terminals, they have high concentration of CP1 receptors in areas of CNS that control pain perception. CP1 like 5,2-arginylglycerol. It's a high efficacy agonist, and anandamide, which is low efficacy agonist, they work on CP1. Immune cells have CB2 receptors in the immune cells, and that may explain cannabinoids' effects on pain and inflammation. And there is 2-AG high efficacy agonist and anandamide, very low efficacy and antagonist. So the more or less they work the same thing, but this is in the immune cell and this is in the peripheral neuron terminals. Re and postnatal neurodevelopmental role of endocannabinoid system. It is involved in nervous system, cell survival, involved in proliferation, Q migration of the neurons, promote neurite outgrowth, direct axonal growth, position cortical interneurons. And from age 6 to 7 to 19, the period of adolescent development, CP1 increase in striatum, prefrontal cortex, and hippocampus, abundant in white matter during neural development, present in oligodendrocytes. And so you can see here that it works on neurogenesis, neurodegeneration, cognitive function, motivation, reward, mood regulation, smooth muscle contractility, lipid and glucose metabolism, appetite, inflammation, nociception, cell growth, and proliferation. Cannabis has, these are two major components, tetrahydrocannabinol and cannabidiol. Cannabidiol is very important product because the THC is a psychoactive anxiogenic, but cannabidiol is not psychoactive anxiolytic anticonvulsant under investigation by NIDA and NIH for therapeutic uses. So a lot of talks about therapeutic use of cannabis is related to cannabidiol, which has no euphoric effect and no addictive ability. THC versus cannabinoid, different binding receptors. THC is a partial agonist على CP1. Cannabinoid does not bind to CB receptors, may interact with 5-HT receptors. THC على CB2 receptor works as partial agonist. So cannabidiol doesn't actually have receptor affinity for either CB1 or CB2. And that explains why it has no mood or psychoactivity, بينما it has other activity as it works on neurotransmitters and interact with 5-HT receptors. THC versus CBD in psychiatric effects. Cannabis with low CBD content, psychosis symptoms, high risk of hallucination and delusion, while the cannabis with high CBD is low risk of hallucination and delusion. CBD alone could be an antipsychotic. It has a possible antipsychotic effect. So this is a big difference where the cannabis itself could be can induce psychosis, بينما CBD could act as antipsychotic. Psychiatric disorder, earlier age of onset if cannabis used with low CBD. Cannabis with high CBD, later age of onset. Cognition, high risk for acute memory impairment with this one, and low risk of acute memory impairment in this one. Anxiety, this is act as anxiogenic, increased amygdalar activity, and this one act as anxiolytic. You all know that people smoke one cigarette of hashish and get panic attacks. This is the anxiogenic effect of cannabis, but anxiolytic effect that reduce amygdalar activity is related to CBD alone, and that's when it's talked about using it as antipsychotic, as an anxiolytic. Approval, these are preparations that have been approved. This is synthetic THC oral capsule approved for chemo-induced nausea and vomiting, appetite boost in AIDS wasting syndrome, and they are classified. This one, Nabilone, is synthetic THC analog oral capsule, chemo-induced nausea and vomiting. Nabiximols, purified 1-to-1 THC and CBD spray, the spasticity caused by MS and pains in MS and in cancer. Epidiolex, plant-derived CBD oral solution used in epilepsy associated with Dravet syndrome and Lennox-Gastaut syndrome. Cannabis versus the synthetics. The THC is a partial agonist على CB1C2, as you know, while synthetic cannabinoids are full agonists, 800 times greater affinity for CP1. And this could give you an idea why these new Spice and K2 and Joker, all these synthetic cannabinoids are causing different effect and many times hallucinogenic effect, and they induce psychosis immediately. They have 800 times greater affinity to CP1. The potential effect of cannabis, it can risk the neurodevelopment, it can impair the short-term memory, concentration, alertness, judgment time, perception, reaction time, and motivation, cause tachycardia and cardiovascular risk, impaired concentration, and impaired fertility. But it can have positive effect on chronic pain, anti-emetic, irritable bowel syndrome, cancer, autoimmune disorders, glaucoma, and wasting syndrome. Effect of chronic heavy cannabis use on endocannabinoid system, reduced anandamide in cerebrospinal fluid, correlate with persistent psychotic symptom. Produced cannabinoid 1 receptor, reduced this cannabinoid 1 receptor and abnormalities in brain regions high in CB1 receptors, hippocampus and prefrontal cortex, associated with higher level of cannabis use, dose, age of onset, and duration. Does cannabis use affect the development of the brain? Yes, it affects the cortical cell death, and it alters the development of major neurotransmitter systems. And that's how it interferes with mental health and has the effect on anxiety disorder, psychosis, depression, motivational syndrome, etc. Does cannabis use affect development of the brain? Yes, it has downregulate CP1 receptor in white matter. Cannabis use disrupt glutamate neurotransmitter. So it has definite effect on development. Does cannabis use affect the developing brain? Yes, it does. And especially if it's used before the age of 18. Does cannabis affect cognitive capacity? In short term, yes. In long term, the data is mixed. Meta-analysis, non-intoxicated users do worse than non-users, but if studies with at least 1 month abstinence, difference is not seen. In other words, it could be reversible effect on cognition. Neuroimaging data inconsistent, don't seem to correlate with neuropsychological test performance. Genetic factors that increase risk of impairment and magnitude and persistence of impairment may depend on frequency and duration of use, age of onset of use, and length of abstinence. Does cannabis use reduce motivation? Yes, this affects high school completion, degree attainment, and thus the users showed reduced striatal dopamine synthesis capacity. In cannabis use, yes, there is reduction in dopamine synthesis. Health effects of cannabis, substantial evidence associated with benefit in chronic pain, chemotherapy-induced nausea, spasticity in multiple sclerosis, moderate evidence for benefits, sleep or obstructive sleep apnea, fibromyalgia, chronic pain, multiple sclerosis, airway dynamics, forced vital capacity, cognition, in psychosis. Associated with risk on respiratory symptoms, motor vehicle crash, low breath weight, psychosis, overdose injuries in pediatric population, impaired learning, memory, attention, increased hypomania in bipolar disorder, depressive disorder, suicidality and suicide completion, social anxiety disorder, development of substance use disorder for other substances. هو بوابة للمواد الأخرى, but there is very limited evidence associated with benefit in increasing appetite and weight loss in HIV patient, spasticity in multiple sclerosis, Tourette syndrome, anxiety, and PTSD. Associated with risk, limited evidence, testicular cancer, MI, ischemic stroke, subarachnoid hemorrhage, pre-diabetes, chronic obstructive pulmonary disease, pregnancy complication, infant admission to neonatal intensive care, impaired academic achievement, increased unemployment, impaired social functioning, increased positive symptoms in schizophrenia, bipolar disorder, anxiety disorder, increased severity of PTSD symptoms, which seems متناقضة. PTSD could be of benefit, but it increased PTSD. Insufficient evidence, will not go into that. Does cannabis use increase the risk of acute psychosis? If you look at the comparison, high in THC, and here you have ketamine, amphetamine, placebo, Salonorine A and Salonorine O, placebo. This healthy human participants, transient-induced psychosis. The transient-induced psychosis was definitely high in THC, high, even in this one comparative to placebo, which is also high in ketamine, but less than THC and very high with Salonorine A. Ketamine and amphetamine data, and these are the references if you are interested. Does cannabis use increase the risk of acute psychosis? In the general population, acute psychosis 1%, in cannabis use 2%. Are there subgroups? 13.7% of US population uses cannabis at least once per year. Risk of psychotic disorder in subgroup, cannabis use 2%. Frequent and high potency use 6%. Users with first degree relatives 20%. So it is higher in certain group. Psychosis risk in adolescents cannabis users, 4-year prospective study using a novel model to test causal relationship with multiple follow-up periods, 3,720 adolescents aged 13 to 16 years. Cannabis use predicted an increased psychosis symptoms a year later. Does cannabis use affect the course of psychotic disorder? Definitely yes. Greater risk of psychosis relapse in non-user. You see it's much lower, and greater risk of psychosis relapse in continued use cannabis users are more clear. Does cannabis improve symptoms of PTSD, bipolar, and depression? Subjective acute improvements in PTSD, reduced nightmares, bipolar, stabilized mood, and depression. A recent review reveals negative long-term outcome of frequent cannabis use in PTSD, 3 studies, bipolar disorder, 5 studies, and depression, 2 studies. Greater symptom severity over time compared to baseline, less remission, reduced improvement associated with recommended treatment. Cannabis use may interfere with treatment, including cognitive behavioral therapy. Stopping cannabis use associated with improved symptom severity. Cannabis efficacy for chronic pain. Systemic reviews have suggested that cannabinoids demonstrate modest effect on pain. The health effect of cannabis and cannabinoids, the current state of evidence and recommendation for research conclusion. There is a substantial evidence that cannabis is an effective treatment for chronic pain in adults. A reduction of conventional pain medication, if it is given with opioids, you could see that those using the use after initiation of cannabis, there is drop of opioids, drop of non-steroidal, and others. However, 3 follow-up studies showed that marijuana use actually increased the risk of opioid abuse. يعني immediate effect إنه بخف الاستعمال as painkiller, but increased marijuana use, cross desensitization, behavioral disinhibition, access to social exposure, pain relief, increased non-medical prescription of opioid use and abuse. Why is medical marijuana not viable prescribed option? Drug approval standard, consistent, pure, well-defined chemical formulation, consistent, well-defined pharmacokinetic profile, safety data in healthy population and specific medical disorder, double-blind, placebo-controlled RCT, efficacy data in specific medical disorders, double-blind, placebo-controlled RCT, warning regard all potential side effects. Medical marijuana status, unprocessed plant containing 500 chemicals with more than 100 cannabinoids. Compounds may vary from plant to plant. Residual impurities, pesticides, and fungal contaminants. Dosing is not well regulated. In summary, wide-ranging role of endocannabinoid system suggests potential therapeutic uses of cannabis, but also potential adverse effects, especially during neurodevelopment. Scant evidence beyond pain in cancer, nausea, vomiting, and spasticity in MS. Approved CBD use in severe pediatric epilepsy. No actual evidence for use in psychiatric conditions, PTSD, anxiety, or depression, because I have seen patients coming from USA claiming that they were prescribed cannabis for depression and anxiety. There is no evidence for that. Variations in potency, cannabinoid constitutes, dosing, and route of administration make medical marijuana difficult to recommend. Potential for use in numerous therapeutic indications, but Schedule 1 status severely limit ability to research. Thank you very much.
Thank you, Dr. Walid, for your scientific and important topic you raised. Indeed, first of all, I should thank all of the presenter for their scientific background and way of presenting different subjects. And probably we consume a lot of time through the presentations, and that make the discussion and questions a bit limited in order not to bother you with too much time. Now we had place for 3 questions, please. In summary, if anyone had a question, and all of us, you can send other questions to respond, but through this meeting, this webinar, to save more time, we accept only 3 questions, and we are waiting from your side. Yes. Ahmed Mazen. Yeah. Zainab. Yeah. Adil Talib. This, if start with the first one.
لازم اللي بده يسأل يفتح الميكروفون عنده.
Yes.
Anyone have a question? Please open the mic.
Yeah.
Dr. Walid, can you close your screen? Share screen?
Yes. Ahmed Mazen is there.
Left. He left. Anyone else? موفق العراقي.
The audience, you need to open your mic to ask, please.
Now in front of me, there are Muhammad.
The audience, you need to open your mic to ask, please.
موفق وهديل. Any one of them, you can start with is head of Africa Studio.
Yes, you need to open your mic to ask,
Yes, please. Thank you so much. Thank you, Dr. Hadil Al-Barak, University ابن سينا University, مسؤولة الإرشاد التربوي والتوجيه النفسي. Thank you so much. It's a privilege to be with all of you. It is a great job. My question is about bipolar disorder, please. Can you hear me? Dr. Hadil Al-Barak, University ابن سينا University, مسؤولة الإرشاد التربوي والتوجيه النفسي. Thank you so much. It's a privilege to be with all of you. It is a great job. My question is about bipolar disorder, please. Can you hear me? Dr. Hadil Al-Barak, University ابن سينا University, I'm not sure if you can hear me. anyway. I'm going to address my question. It's about diagnosis bipolar disorder 1 and 2 in Iraq. Is there any institute or clinic regarding this subject, please? Thank you so much.
Mr. Muhannad? Yeah.
دكتور بتقدر تجاوب على السؤال بليز؟
Indeed, the question is not related to any topics of the subjects we the question, but still towards the I call part of general in any psychiatric consultation clinic. In specific, to my knowledge, there is no area to diagnose or manage this disorder alone. In Baghdad, I know about hospitals, I know about clinics, Kurdistan region also. There are criteria, definitely, that taking history, work history, and upon new criteria for the psychiatrist is able to diagnose and manage the condition. I hope if any colleague has further ideas to share with us. Second question, I think Dr. Roche, if he is online, yeah.
Dr. Karim Aziz.
Unfortunately, the voice is not clear at all. I'm so sorry. I couldn't hear the answer.
Hello, Doctor.
Minu?
Dr. Karim.
Hello, Doctor. I am Dr. Karim. My question to Dr. Youssef, how, Dr. Karim, أنا Dr. Karim.
أهلا وسهلا.
How we do, hello, to Dr. Youssef, how we do, how we do adaptation, how we do adaptation with social media.
Dr. Youssef, you can open your mic and answer
with social media.
Yes,
thank you. To be depend on the official media like Ministry of Health or WHO.
Yes.
Please.
Thank you very much, Dr. Karim, for your question and comment. Really, controlling the social media is not easy. You cannot control the social media, the pages, who are behind the pages, because you know it is not so easy. But it needs the effort from the other side to face, to combat in a regular way, especially the governmental, Ministry of Health, Ministry of Higher Education, Ministry of Culture, Ministry of the Religious Affairs, and non-government agency like Iraqi Psychiatric Association, Kurdistan Psychiatric Association, other association, not to let this field without fighting really. Because it has, for me, one of the common source of the stress or separating anxiety was the social media and wrong use. So yeah, you are right, it is not so easy, but the field should not be empty for those, and through the regular program, and you can deal with it.
Last question, please.
Thank you.
Have in front of me Noura, unknown, UM, Zulfiqar Haider, any one of them, Aza Taha. The floor for last question, please.
السلام عليكم.
وعليكم.
تسمعوني دكتور سيروان؟
نعم، منو حضرتك؟
معكم دكتور ذوالفقار حيدر مستشفى بن رشد.
يا سر الدكتور ذوالفقار. تفضل.
تحية حارة للجميع وسلامي للجميع أساتذة ومحاضرين، وعاشتكم على المحاضرة القيمة والممتعة. عندي سؤال دكتور عماد مستشار الوطني للصحة النفسية.
تفضل دكتور.
نعم دكتور عماد، دا أسأل عن الدراسة اللي سويتوها على السايكولوجيكال سيكولي during كوفيد بانديميك. الدراسة أجريتوها على الهيلث وركر.
كمل السؤال دكتور ذوالفقار حتى يجاوبنا دكتور.
أوكي. سؤالي السامبل منو كانوا؟ أطباء، ممرضين، هيلث وركرز، منو بالضبط؟ إذا جواب كان نعم، أريد أعرف بالدراسة مالتكم إيش قد طلعت نسبة الإنسومنية، وإيش قد طلع نسبة الستريس، الشدة النفسية على أثر الكوفيد بانديميك بالعراق.
شكرا دكتور ذوالفقار. دكتور عماد.
نعم، شكرا جزيلا. I mentioned that they are not doctors. They are workers and they have different educational level. يعني اللي يعملون بالوزارة الصحة، مقر وزارة الصحة، قسم بهم أطباء، قسم خريجين كليات، يعني قسم ممرضين، قسم خريج إدارة اقتصاد، يعني different fields. الانسومنيا كانت percentage of insomnia 39%, I think, I remember. And we have the sadness as a symptoms reached to 40%, the percentage of sadness. And we have, as I mentioned, the fear from infection about 44, and fear from spread of the disease about 46. So this is the figures.
Thank you.
اوكي، شكرا دكتور عماد. بالدراسة هم سويتوا كويستشنير او استبيان عن الشدة النفسية، ستريس، الضغوط؟
عندنا دراسة أخرى راح نبدي بها على العاملين في الحجر الصحي، راح تكون على الضغوط وعن الانكزايتي وديبرشن. إن شاء الله الويبينار القادم نقدمها إن شاء الله.
إن شاء الله، كل التوفيق. آخر سؤال وانهي، بالدومستيك فايلنس بالدراسة مالتكم طلع 4 point something، 4
domestic 4.2 domestic violence.
يعني لا أشوفها قليلة.
I mentioned that is a small number. I think they are denying giving the correct answers about. But in addition, we have now a study on domestic violence with the Ministry of Interior. They have a department for family protection, and this is referring cases for police, and we have this another study for 6 months.
Thank you. Before the session, may I ask Mr. Mohanad if there is time to let Dr. Rawsht Rashid, Director of Mental Hospital in Erbil and Head of Psychiatric Association, he sent me a message. He wants to have some input to the talks, if you can.
Please ask him to join. I'm waiting.
Dr. Rawsht. Just few seconds. We wait if he can.
Yeah, he joined already.
The mic.
Hello, everybody. Dr. Sirwan, do you hear me now? Dr. Sirwan?
Yeah.
Dr. Sirwan, do you hear me?
I hear you clearly. Yeah. Your voice is clear. You can talk.
Okay, thank you very much for the organizers of this webinar, and thank you very much for the speakers.
Okay.
I think there is a delay, but it's okay. I will continue talking. So my first question is to Dr. Walid Sarhan regarding the efficacy of transmagnetic stimulation, TMS. Is it, in Jordan and in Arab countries, do you use it, and what's the efficacy of it in the treatment of depression specifically? And my other question is to Dr. Youssef Indahok.
غير واضح السؤال.
That the psychiatrists themselves were successful in managing this effect of the social media and media on the psychology of people during the COVID-19 crisis. And what did you mean that it's the job of the associations, like, for example, psychiatric associations, to deal with this problem? Thank you very much.
Dr. Rawish, السؤال الأول is not clear. I think the second question is somewhat clear. The sound is not clear, reached to Dr. Walid. He asked if you repeat the question, please. The first one.
Okay, my question is that about the efficacy of TMS in the management of depression. Okay. Is it clear now?
Yeah.
And the second question?
To Dr. Youssef about social media.
Okay. TMS has been shown to be effective in treatment of resistant depression, and the problem that is the practicality that you need to give it daily 5 days a week for 6 weeks. This is very difficult in clinical practice. Now there are development going on to improve the machine and to change the schedule so it may become twice a week and not for 6 weeks, maybe less than that. It has been shown effective mainly in depression, to some extent in other disorders like OCD, and in some neurological disorders that is more established in Parkinson's disease. It's the problem also that it's not, it doesn't really mean that you are like ECT. You don't get rid of the medication, you still have to carry on with medication. The procedure and the application is smooth and easy, but the frequency of sessions have made it less widely spread worldwide. We have 2 equipments in Amman. We hardly use them because of this regimen that people have to come 6 weeks, 5 times a week, which is really difficult. And the patient would rather get ECT in 3 weeks and finish that. Thank you.
Dr. Youssef, do you hear his question?
Yes, Dr. Sirwan, it was very clear and obvious. Yes, can I answer?
Yeah.
Thank you, Dr. Rausht, for your question, comment. Really what I mean, social media, because it is a source of the stress, spreading the stress and anxiety and disrupting the mental health. So fighting this is not job just of the association, psychiatric association. You are totally right. But we will talk about our part, because now we are here, mostly we are Kurdistan Psychiatric Association, Iraqi Psychiatric Association. So we have also responsibility to fight, to face, to combat about this. But it is not totally, not just the psychiatric association that are responsible. Governmental, the Ministry of Health, yes, the medical health education is one important part of the providing the health to the people. Education, health education should be more powerful, enhancing, take its responsibility more. And other non-NGO like the Doctor Syndicate, of course. So it is not, you are totally right, not the responsibility alone of the psychiatric associations, whether Kurdistan or Iraqi, but we also, because for example, when you are talking about the stress, one of the point, don't look to the information that are not 100% right. Don't use the pages that not providing real or scientific information. So I mean, we should take our responsibility on our part. يعني جزء منه على عاتقنا أكيد وليس الكل.
Thank you, Dr. Youssef. Sorry to say, I hear from the admin that there are questions written, but I couldn't find it. Probably, if any one of your colleagues can see the questions, I couldn't see question behind the screen. Because of the time, we are sorry to say, indeed, it was a very nice, stimulating webinar. We hope that we were able to let you understand and cooperate with us through the sessions, and we aim in the future to have similar events, probably more organized and giving the chance for audience for more questions and comments and ideas. And if there is no any special talks from Professor Walid or Dr. Imad or Dr. Youssef or Abdel Hamid or Bara'a.
إذا سمحت لي دكتور سروان، يعني أنا في نهاية الويبينار بشكر الزملاء في العراق وتكريمي بالمشاركة في هذا الويبينار، ودائما أنا في خدمة الأخوة في العراق، ودائما جاهز لأي طلبات في المستقبل.
ما تقصر، سلمت. We can say goodbye and hope you the best of health and away from this pandemic and good mood and healthy with your family. Thank you again and good night.